Hello everyone, welcome to podcast 10 of Let's Revise MBBS, and today's topic is metabolic changes and diabetes in pregnancy. Okay, so what do you think is the average weight gain during the pregnancy? So it depends on BMI or the previous weight of the female before she gets pregnant, but still if you say average, like if you consider normal BMI, then her average weight gain is between 12 to 14 kgs. Okay, if she is underweight, her weight gain can be up to 18 kgs is also normal. If she is obese, then her weight gain shouldn't be more than 7 kgs. Right. Now, and her BMI during the the basal metabolic rate during the pregnancy also increases by 20%. Okay, now let's talk about the metabolism of three main compounds, that is proteins, fats and carbohydrates. So protein, the demand of protein increases during pregnancy because the fetus also requires it. So demand increases, but the concentration of protein decreases. Same concept applies as we have seen in hematology. So same here also, that the concentration of protein decreases. Normally the concentration of protein is 7 gram per dl. In pregnancy it becomes around 6 gram per dl. Okay, and what is the effect on Ag ratio, albumin globulin ratio? It also decreases. Initially it is 1.7:1. Now after pregnancy it is 1:1. Okay, coming on to fat. So in fats there is hyperlipidemia. So all types of lipids like low LDL, VLDL, cholesterol, HDL, all of them increase. Okay, and lastly coming on to carbohydrates, as we have seen that the pregnancy is diabetogenic state. What are the main hormones responsible for this? If you are asked one, you will go for HPL, human placental lactogen, and then the rest are estrogen, progesterone and other hormones. But one thing to remember here is that HCG does not contribute anything to this diabetogenic state of pregnancy. Okay, why in the first case do we need to keep the glucose high? Why do we need the pregnant woman to be in the diabetogenic state? Because the fetus is dependent on the mother for glucose, right? And this glucose goes into the fetus by facilitated diffusion with the help of receptors GLUT1 and GLUT3. So the glucose concentration in mother should be high. That's why there is a diabetogenic state. Okay, and since there is a diabetogenic state, we advise female to take small but frequent meals. Okay, if she doesn't do so, if she takes one heavy meal and does not have anything for a long time, she will have postprandial hyperglycemia but fasting hypoglycemia. So there will be a lot of fluctuations in her glucose level. Okay, so obviously as this is a diabetogenic state, we can say that diabetes can be common in pregnancy. So we have seen about diabetes. Why diabetes occurs in pregnancy? We have seen that by the carbohydrate metabolism. Now we will see types of diabetes, how should we diagnose and how should we manage, and the complications of diabetes in pregnancy. Okay, so basically diabetes is of two types. One is gestational diabetes and the other is overt diabetes. As the name just suggests, gestational is during the pregnancy. So this is a diabetes which occurs only during pregnancy and only because of the pregnancy. Okay, so what did we see? What is the main hormone which antagonizes insulin? That is HPL. So the level of HPL goes on increasing from the first trimester till the third trimester. So when will the gestational diabetes be more common? Obviously in the third trimester, because the concentration of HPL is very high. Okay, and this HPL makes the body cells resistant to insulin. Okay, they do not respond to the levels of insulin. That's why because of HPL, there is gestational diabetes. But ideal time to detect this gestational diabetes is between 24 to 28 weeks. Okay, and as this is only due to pregnancy, it will resolve after she delivers. It resolves within 6 weeks. Okay, because the placenta was the cause, right? Similarly, in the further podcasts, when we will study about PIH, pregnancy-induced hypertension or preeclampsia, even there we will see that it resolves after pregnancy because it is also because of placenta. Okay, and since this gestational diabetes occurs after the second trimester or in the second or third trimester, there are no chances of congenital malformations because you know that. Okay, coming on to the overt diabetes. Overt is what? Pre-existing diabetes. Okay, from day one she is having diabetes, which may be type 1 or type 2, and then it gets overadded or it gets aggravated because of the pregnancy. So this overt diabetes will obviously not resolve even after delivery because it was pre-existing, right? And the chances of congenital malformations are very high in overt diabetes because during the phase of organogenesis the blood glucose levels are very high in the first trimester also. Okay, so how do we diagnose diabetes? So we do OGTT test, which is oral glucose tolerance test, and Dipsy guidelines are followed in India. Okay, there are 2 or 3 guidelines, but we will mainly focus on Dipsy. What is Dipsy? Diabetes in Pregnancy Study Group of India, DIPSI. So we do Dipsy test, with 75 grams of glucose, okay, oral glucose, and there is no fasting required. It's not required that the patient while coming to the doctor should be fasted for 8 to 10 hours, nothing like that. Okay, so Dipsy is performed twice during the pregnancy. First in the first visit, whenever she visits the doctor first time. Why do we do this? To rule out overt diabetes, okay, to rule out any pre-existing diabetes, and then we again do this Dipsy in 24 to 28 weeks to rule out gestational diabetes. Okay, so if she visits the doctor for the first time, we do her Dipsy test. Okay, if it's normal, then she does not have overt diabetes, okay, or pre-existing diabetes. We can come to this conclusion after the first visit. Okay, but if the results are abnormal, like if her fasting glucose is more than 126, if her postprandial is more than 200, or her HbA1c levels are more than 6.5%, then we diagnose overt diabetes. This is in the first visit. Now her pregnancy. Now let's consider that the results of the first visit were normal. Okay. Now her entire during 24 to 28 weeks, nothing went wrong. She came back for the visit. Then we again do Dipsy test. We give her 75 grams of glucose, and 2 hours later we check her blood sugar level. Okay, if it is more than 140, then we label it as gestational diabetes mellitus. If it is, okay, this is postprandial, right? 2 hours after 75 grams of glucose. So if it is more than 140, we'll straight away label it as gestational diabetes mellitus. Okay, and treatment for both of these, for overt as well as for gestational, is drug of choice is insulin. Right? Why is the insulin drug of choice in pregnancy? 2 reasons. It is effective. It is more effective as compared to oral hypoglycemics, and it does not cross placenta. So these are the 2 reasons why insulin is preferred. Okay, most of the oral hypoglycemics are contraindicated except 2. Do you know them? Okay, first one is metformin and the other one is glyburide. Okay, why are these not contraindicated? They cross placenta. Like other oral hypoglycemics, even these 2 drugs cross placenta. But there is no proven teratogenicity of these 2 drugs. Therefore, these drugs can be given. But the overall drug of choice is still insulin. Okay. When is insulin indicated? When the fasting blood sugar level is more than 105 milligram per dl. Okay, and what target do we have? The target for us is that fasting blood sugar level should be less than 95, 1 hour postprandial should be less than 140, and 2 hours postprandial should be less than 120. This is the target that we want to achieve after giving insulin. Okay, along with insulin, obviously we'll advise her some dietary changes and all. but the insulin is mainstay of treatment. Okay. Next question arises: when should we terminate the pregnancy in diabetic females or the females having gestational diabetes? So, as you know that insulin prevents or limits the formation of surfactant in the lungs. Why? Because there is a protein SPA, soluble protein A, which is important in formation of surfactant, and the insulin inhibits formation of this protein. That's why the production of surfactant in the fetal lungs is delayed. And therefore, if we terminate the pregnancy of diabetic mother early, like around 37 or 36 weeks, it can cause RDS in the infant. So we preferably terminate the pregnancy if her glucose levels and everything is well maintained. We prefer to terminate her pregnancy at 39 or 40 weeks, not before that. Okay, you have understood why. Right. Now coming on to the complications of diabetes. So let's talk about antenatal complications. So we had discussed previously in amniotic fluid wala podcast that diabetes leads to polyhydramnios. Why? Because more glucose in fetus, polyuria can lead to polyhydramnios. So because of polyhydramnios, there will be stretching of uterus, right? If there is stretching, the fetus has a lot of space to move, then there can be malpresentation. Due to stretching, there can be abruption of the placenta, so abruptio placenta. Okay, and the fetus may deliver early, that is preterm. So these are the complications of preterm. Now intranatally, during the delivery, there can be uterine inertia. Why? Again the same reason. Due to polyhydramnios, the uterus is stretched a lot and therefore its contractility decreases. So there is uterine inertia. And during the delivery, there can be shoulder dystocia. Okay. One more thing, in antenatal complications, macrosomia is very common. Okay. Why is macrosomia common? Because during the entire period of pregnancy, or at least after 24 weeks, there is a lot of glucose going in the fetus, and all the cells grow in size, and therefore there is macrosomia. How do you define macrosomia? When the weight of the fetus is more than 4.5 kgs, or the abdominal circumference is more than 35 centimeters, right? We have discussed this. So abdominal circumference and weight, on these two criteria we determine whether the fetus is macrosomia or IUGR, right? And there can be chances of congenital malformations also, but this is only in case of overt diabetes, not in gestational diabetes. Okay, and the chances of congenital malformation depends on the level of HbA1c. Okay, the higher the levels of HbA1c, the risk of congenital malformations also increase. Right, so this we saw about complications, antenatal complications and intranatal complications. Let's see about postnatal complications. The most common postnatal complication is PPH, the postpartum hemorrhage. Again, you can relate this to polyhydramnios. Polyhydramnios causes excessive stretching. Excessive stretching causes uterine inertia. So when there is delivery of placenta, there are crisscross fibers in the uterus which act as living ligature, but these are not able to contract because of uterine inertia, and this can lead to PPH. Okay, right, and this further can lead to sepsis. So these are postnatal complications. Coming on to the neonatal complication. After the baby is born, what complication he can have? First one is hypoglycemia. You know the reason of hypoglycemia. Initially, during the pregnancy, there is a lot of insulin coming from the mother to the fetus. In response to this, the fetus was secreting, I said insulin, I guess, yeah. So I'll repeat, during the pregnancy, there's a lot of glucose coming from mother to the neonate, to the fetus, right, during the pregnancy. In response to this high amount of glucose, the fetus was secreting high amount of insulin, okay, to maintain his blood sugar levels. But when he is delivered, the source of glucose is cut, but his pancreas will still secrete a lot of insulin. Okay, So that's why he will go into hypoglycemia. And how do we define hypoglycemia in a neonate? Blood sugar of less than 40 mg per dl is hypoglycemia. Okay, this is one important complication, and the other complication can obviously be RDS, as we have discussed, if the delivery is preterm or even early term. Okay, it can lead to RDS. Now coming on to the last but final very important points. These points you will have to remember. So talking about congenital anomalies, what is the most common system involved in diabetes? It is cardiovascular system. Okay, congenital anomalies are very common in congenital CVS. Okay, congenitally very common in cardiovascular system. In CVS, the most common is VSD, ventricular septal defect is most common, but most specific for diabetes is TGA, transposition of great arteries, if you specifically talk about CVS, cardiovascular system. But if you are asked overall what is most specific congenital malformation in diabetes, it is sacral agenesis. Okay, so three things we saw: VSD, which is most common, TGA, which is most specific in cardiovascular system, and most specific overall is sacral agenesis. Okay, and final point, beta agonists, which can be used as tocolytics, are contraindicated in females having diabetes, like ritodrine, isoxapurin, terbutaline, salbutamol. These tocolytics are contraindicated in diabetic females. Why? Because these can lead to hyperglycemia. This can further aggravate hyperglycemia. The reason for this is that these beta agonists act on pancreas. Okay, they act on beta cells as well as alpha cells. So they will increase insulin, but already the cells are less sensitive to insulin. So the increase in insulin will not have much effect, but they will also increase other hormones like glucagon, and this glucagon can lead to hyperglycemia, right? So that's why beta agonists are contraindicated in diabetic females. Okay, so that's all from diabetes and metabolic changes. We'll meet tomorrow. Okay, till then keep studying and enjoy. See you.